So it's the new definition, no, sir?
It's not a new definition, to be honest. So it's existing definition. It's abnormal focal permanent dilatation. That's right. So these things should be there. Abnormal focal. One main problem thing is about focal and permanent dilatation. That's right.
That size 50% change, sir, is it newly added thing?
No, it is. It has been there right throughout. 50%. It has to increase by more than 50% for you to say it's aneurysm. And unless it happens up to that level, you don't call it aneurysm. And before that, I said it's ectasia. The term you use is ectasia. Is that clear?
Yes, yeah. Yes, sir. And one other question, sir, in that if there were statements like, sir, that pseudoaneurysm is always saccular and true aneurysms are always fusiform, is it true, sir?
No, it's not true. Fusiform aneurysms are usually fusiform, right? False aneurysms are almost always saccular. Okay, but the true aneurysms can be saccular as well. Like, for example, berry aneurysms of your brain addresses, so you can get berry aneurysms. They are saccular. Okay, so they contain all three layers of the vessel wall, but it can be saccular. The problem with saccular aneurysm is that it has higher chance of rupture. I'll talk about later on the management of it. But main problem with saccular aneurysm is higher chance of rupture compared to the fusiform aneurysm. Okay, so have you all rejoined? Just 111 people altogether now. There are about 200 people work there. So, so there are finalist students also here?
Yes, sir. We also...
That's good. We can accommodate about 300 people. So that's no problem. Yeah.
So we got a message saying that you have postponed the lecture for tomorrow morning, I think.
Yes, I did so. I did so because there was a severe, rain here and thundering and lightning, and all of a sudden the light went off, and my internet connection got disconnected, and then I couldn't have no way of communicating. That was a problem. Now you all settled down.
So I think if you could wait like another 5 minutes, I think we can get the message around and...
Yeah, sure. No problem. I'll wait for 5 minutes.
Thank you, sir.
No problem. So Supun, you all study now for the final year, do you?
Yes, sir. Now we have like date is like almost fixed for 8th of June, sir.
Have you got the date now?
It's still unofficial, sir. Various, the board of deans recommended that we do that on 8th and
8th of July, is it?
June, sir. June.
June. So another month to go, actually, more than 1 month. So time for you to study, isn't it?
Yeah, but sir, it's in Japura they have informed the students that it's gonna be 8, but from the Colombo they are sitting for the repeat, no, sir. They have informed that there is no fixed date or starting date or anything yet.
Correct. I think we haven't still. Can't predict the date we can start these things because this COVID situation still quite unstable, isn't it? We don't know where it will end. Even though the country has opened up, still I really doubt that they have the other flare up, and then they will have to shut down everything. But it's a pandemic, and it can come back again at any stage. Here, because we don't have a good cure or good remedy or vaccine for the virus, so only way we can curtail this by source control. That's what we have done so far. So far, so good. I think it's thanks to the army and all these forces they are keeping and everything at hold. So I don't know personally whether the universities can start early. I haven't got any message. So Supun, it's a good time for you to study, isn't it?
Yes, sir. Now for now, sir, we have set. I mean, we are set have set the date for it and working towards that, sir.
Mm, mm, mm. And you can perform very well. Huh? Lot of ample time for you to study. Uh, so, and you had clinicals also, didn't you? You all have finished clinicals, haven't you?
Yes, sir. We did.
Mm. So, you all have much advantage. So, study as much as possible, and then the depth. And I see much of a difference between you guys and the Colombo University students because they are much more knowledgeable in theory wise and when it comes to the exam. So don't be inferior to anyone. So try and do your maximum. So that is important for you and for your future career. So so that's very important to upgrade your knowledge. Okay,
Okay, I will.
right. So are these students back? 129. I'll wait for some more time. There are about 160 people. Eh? So are you all happy with this Zoom now? You all get much as you wanted?
Yes, sir. Now it's quite a bit of sessions, sir. Today we also had a pediatric session, also
Mm-hmm.
pediatric department, and also we had made also early in the morning we had gynecology and obstetric session too, sir. It's very
Mm-hmm.
helpful, sir, because
Yeah,
mm,
yeah. And the advantage of that is that every batch members or anyone can join it. So anyone who is interested can join and get some knowledge. And also, I feel that you feel much more free to talk, isn't it? Because
yes, sir.
like you don't have much of pressure or peer pressure or whatever the pressure, and no much of stress. You talk like this. It's like talking over the telephone. Uh, so it should be okay.
Hello, sir.
Yeah, Saranga.
Hello, sir. Sir mentioned that what's the problem with the MRI angiogram in the when diagnosing compared to CT angiogram?
Yeah, yeah. So
Uh,
problem is it takes time for you to reconstruct and get the images because MRI. Have you seen MRI machine? It's there
yes,
in
sir.
it's there in Ragaman. So use your chamber and you insert the patient inside, and then we have to wait until you get the magnetic field, and then to reconstruct get the images, it takes about half an hour at least. So if the patient is quite unstable, like rupture, whatever, aneurysm, so you can't keep patients there in that room for a long time. So you have to have a quick diagnosis and all these things. But it's quite good for stable patients. Uh, and also it's costly. That's another thing. For you to get a MRI images in private sector, it costs about 20,000 to 30,000 rupees. Whereas CT will be about 12,000, 15,000. But government is the same because it's more costly, I think, more than the private sector because you get a lot of people involved, including radiographers and radiologists. They are being paid in hospital, so it's costly.
Okay, sir. What is the difference in the risk of rupture related to the gender? Sir, I couldn't hear that.
Yeah, the females are more prone to rupture when it reaches certain size compared to males. Okay, so like for example, I said now abdominal artery aneurysms do rupture when it reaches 5.5 centimeters in size in diameter. Okay, in males, but in females, that happens. The rupture will happen at about 4.5 centimeter, 5 centimeter in size. So that is the nature. So they are more prone to rupture before it reaches that significant size. Okay.
Okay, sir. Thank you.
Yeah.
Okay, thank you, sir.
Okay. Any more questions so far?
Sir, hello.
Yeah.
Sir, once aneurysm is ruptured, can we feel it as a pulsatile lump?
Yes, we do. What happens after rupture is that most of the time, the aorta is a retroperitoneal structure. So in retroperitoneal, there's a peritoneal cover. So usually it ruptures posteriorly or posterolaterally. When it happens, so it forms a hematoma, and it contains the contained hematoma. Okay, and when this happens, so it will hold up the expansion or the extravasation of blood for some time. So as a result, you can feel a lump, bigger lump, much bigger lump than before, and it's expansive because of the aortic pulsations. But that's not going to hold it forever. It will hold for some time before you get another bleeding, because the containing hematoma wall will give away at some time, some stage, because of the internal pressure. So that's why initially you get a kind of a fainting attack due to rupture, and then after a while you gain consciousness and blood pressure is barely maintaining, and later another one or 2 days, some of the patients, that will rupture again and accelerate and lead to exsanguination and death. So that's what happens. So clinically, the abdomen will be tender touch. You can feel epigastric mass, tender epigastric mass, which is pulsate.
Thank you, sir. Sir, one more question, sir.
Yeah.
From the palpation and pulsality, can we differentiate the pseudo one and true aneurysm?
Palpation alone is difficult. Usually, you can't say it's a pseudoaneurysm or this thing, but you need to get the compatible history also. Like pseudoaneurysms do happen due to previous trauma most of the time. I said now we do a lot of interventions. The cardiologists do a lot of interventions. That's called percutaneous coronary interventions, PCI. Where you gain access to the coronary arteries to peripheral blood vessels. Most of the time they go to the femoral artery. Sometimes they go to the radial artery. So you get a history like that. It's a puncture of the blood vessel. So that's if there's a kind of a expansile pulsatile lump there in the access site in the femoral radial artery, so it's more compatible pseudoaneurysm. So likewise, so there will be some history like that, of pseudoaneurysm. Or there will be a mycotic aneurysm. They are usually circular, and there sometimes they can be mycotic aneurysm can be a pseudoaneurysm. And then likewise there should be some history, but examination alone will be difficult unless you get history compatible with that. All right, Hasta?
Thank you, sir.
Okay. Oh no, it's again raining. I don't know whether this will continue. And, these days we get very bad weather. I don't know, it's towards especially the evening. Shall we start then? Hello? Are you all there?
Okay, sir, I think we can start now, sir.
Sorry?
Yes, sir, I think now we can start, sir.
Yeah, good. So please do interrupt me at any time, so because we have to make it more interactive. Otherwise, we can't continue because my internet connection is somewhat down. Sometimes I don't know whether you are listening or not. So just continuously keep interacting. So this is where we stopped, didn't we? So I have to record also. Okay. Shall we start then?
Okay, sir.
All right. So let's get back to the previous case scenarios. Now you see this 80-year-old gentleman, chronic smoker, and a lot of comorbidities including hypertension, COPD, ischemic heart disease. So presenting with this um, clinical features of low blood pressure. You know, remember this 100 by 50 millimeter mercury blood pressure is in a hypertensive patient. It's not normal. Okay, it is hypo. It is hypotension, relative hypotension compared to other individuals. And the heart rate is 100 is tachycardic, respiratory rate is somewhat increased, and abdomen reveals calcitine mass. So, how do you assess this patient further? What would you do? Can somebody tell me what you're going to do for this patient? What do you think? Those final year students, can someone tell what you're going to do or at this stage? Support?
Uh, Sir, this patient seems like, sir, he had the aneurysm have ruptured, sir.
Yeah.
Due to
Why
the,
do you say it's ruptured?
it's a sudden onset low abdominal pain, sir,
Okay.
and also he has had a fainting episode,
Yeah.
and also in
It's a
his
significance of painting episode.
what's the
What's the significance of painting episode?
it could mean, sir, he has bled a lot and he has become hypertensive and he's uh, that has the cerebral hypoxemia
Yes.
has caused the
Yeah.
fainting, sir.
Yeah.
So, sir, this is a medical emergency. We should immediately attend to the patient
Mm-hmm.
and should go through ABC steps
Mm-hmm.
and try to resuscitate the patient.
Mm-hmm.
And after that, sir, if the time permits, we can go for like abdominal ultrasound scan and
Mm-hmm.
confirm. After
Mm-hmm.
that, sir, it should. If I'm the intern house officer, I would immediately inform my surgical seniors, theater
Mm-hmm.
staff, and anesthetist, and
Mm-hmm.
would immediately arrange the patient to taken to the theater and then to repair the aneurysms.
Right. Good, Supun. But you miss some other things. Your assessment should include a brief history or rapid, very brief, concise history to get more information about the patients. Now, this is all what you are given, but there are many other underlying problems. Okay. So let's talk one by one. So the history. So he's a chronic smoker, 80-year-old man. Okay. So he's quite close to death anyway, because usually life expectancy of people in Sri Lanka, wherever, is somewhere 80 to 90, isn't it? So you're going to die at one some stage or the other, whatever you do. So 80 all means sometimes, okay, you think whether you want to do any heroic operation or not, you might have to think twice. Other thing is chronic smoker. So he's anyway a bad chap. He had bad chap of going chronic smoking. So what happens when you do smoke for some time? There are a lot of changes in the blood vessels, especially the lungs and also the blood vessels. They are affected terribly. Lungs suffer a lot due to smoke, and they leads to COPD. You know the pathophysiology behind COPD, emphysema and chronic bronchitis. You all have learned in pathology, have you all? So this leads to COPD and they are bad lung, bad chest. So they may be oxygen dependent sometimes. So we need to get more details of the status of his the day-to-day activities, what he can do. He may be a bed-bound patient or maybe oxygen dependent patient at home. Right? Never know. So you need to get more details about this. But it just takes a couple of minutes to take all these details. So it's true it's an emergency, but you just need to focus history. And then came to a casualty one with abdominal pain and back pain. Are there any similar kind of other conditions which can present like this? So abdominal and back pain. Anyone? Other diseases which can come like this?
Pancreatitis?
Aortic dissection.
Yes, aortic dissection if possible. Pancreatitis, yes. Yes. Okay. What else? Let's forget about the rest, but we are talking about the abdominal pain and back pain. Anyone with abdominal pain, back pain? There are a lot of other structures in abdomen. We have to think about that.
Sir, renal colic.
Renal colic usually, yeah, you get a typical history, radiating pain on all sudden onset. Yeah, but if you focus more the other abdominal organs like the gallbladder, the biliary system, all these things, upper abdomen. If the lower abdomen, you think about the bladder and kidney, and also all the other structures and colon. Anyway, so you had to rule out the other possibility as well before you get embark on any operation. Okay, so you have to clinically prove that this patient has nothing other than the ruptured aneurysm. The history, other thing is we need to ask any history of previously known aneurysm. Sometimes patient might have had a diagnosis done by somebody that this patient has a large aneurysm and he is not fit for any operation, elective operation. You get that point? So elective basis, he was not suitable. So that may be a diagnosis card he's carrying. So you have to go through the past records. Okay, now let's get back to the other thing. COPD patients are normally having a predisposition to develop aneurysms. That's because COPD is a kind of a degenerative condition, and when your lungs get bad due to chronic smoking, so is the blood vessels, especially the aorta. Aortic wall degenerate, and that causes expansion of the wall and causes aneurysm. So COPD and aneurysms are coexistent. So always think when there's aneurysm when you get a COPD patient. Hi. The other thing is about hypertension. Hypertension risk factors. Hypertension is one of the very strong risk factor. So it leads to expansion. You know the law of Laplace. Do you all know? Have you all heard law of Laplace in physiology? Hello. You all need to talk. Yes. So you know the tension and the pressure and the radius. So the relationship between all these things. So when the pressure inside is constant, say that the blood pressure is quite normal. When the arterial wall increases, or the wall of the balloon increases, the tension in the wall becomes higher. That's according to the law of
Jim.
Hello, are you there?
Yes, sir.
Yes.
Sir,
Okay. Power failure again. Okay, a lot of interruptions. Shall we carry on? So, hello?
Okay.
Yeah. Okay. So I was talking about this, the COPD and also the aneurysms and the low blood plus. Share my screen and record. I can't record it for some reason. Is that so? How do I become the? I don't know. Can someone record it then? Hello? Who can record? How did it happen? Hmm.
So I think the same thing happened the last time also.
Ah.
So Rohan sir had to turn off the session and then restart it again.
Is that so?
Yes,
Shall
sir.
I turn off and restart again then?
Sir, a student called Tisari is the host now. Maybe she.
Ask her to record then, please. Is she there or is she just putting mute and then saying somewhere else? Hello. Can you all record it then? All right. Okay. So yeah. So I was talking about this low blood plus, and so when the tension in the wall increases compared to the time. Even though the pressure inside is similar, so it will rupture because there's some increase in tension when the size increases and it ruptures. So suppose the patient is having a hypertension, the pressure also increases, and that leads to a increase in rupture risk. That is why the controlling hypertension or the blood pressure is very important. Hypertensive patient to prevent the expansion and the progression. Okay. Excess stress demand, and then aneurysm repair. This thing is a major operation, and you need to have a lot of cardiovascular reserve for you to sustain that big operation. So when your heart is compromised, you are not a fit guy, fit person to undergo that kind of bigger procedure. So in otherwise, you can't operate on these kind of operations. So just leave and, calm and quiet, rest, make him rest in peace. Okay, like Einstein did. All right, but let's get back to the management again. So this is what you will see on rupture. So you see a retroperitoneal hematoma. It's a contained hematoma behind the aorta, and so this is what you see in CT scan. This red color is not what you see in CT, but it is just made for your description. Are you all there still? Yes, sir. Okay. So how are you going to fix this problem? Forget about the case scenario, patients to die with some pain relief and all, but there are most of our situations we can do operate. Okay, let's talk about the history, and so this is what how it has evolved. So atherosclerosis is a process which was understood even about 3,500 years ago. It was described by Egyptian mummies. And so atherosclerosis is one of the most common reasons for atherosclerosis, aneurysms. It was written in Egypt's papyrus, so this aneurysm, how it happens and how to treat it. So it says treat it with a knife and burn it with a fire so that it bleeds not too much. So you can imagine type of operations people have done to fix this in ancient era. So, and John Hunter is the first surgeon who actually has done a heroic operation, who had made successful operation. He basically ligated the blood vessel. He is somebody with a popliteal aneurysm, but there's something a popliteal artery aneurysm. So what he did was ligation of the artery above that. That's called superficial femoral artery. He ligated it and he successfully treated it. But he might have eventually lost the leg. That's a different situation. But he had made a successful operation. That's a different thing, isn't it? Okay. So in 1923, Matas performed the first successful artery ligation, and he actually survived for 18 months before succumbing to tuberculosis because apparently the aneurysm might have been due to TB. So his surgeon actually ligated the aorta, but you might imagine that aortic ligation by that time must have been very inhuman kind of thing because there was not much of anesthesia by that time. So sometimes you you don't have halothane, we give other the procedures, the inhaling agents. So something like chloroform. So you do operations under that. Kind of a brave surgeon, isn't it? So the patient had made recovery until and lived for 18 months by that time. Okay, so this is how it has evolved. So how do you manage this? It depends on the patient's symptoms, size, height, complications, and the type of the artery involved. Either is an end artery or it has a dual blood supply, like radial artery. You can sometimes compromise. Um, uh, do you have any problems? Okay. Somebody made private messages here. Okay. Okay. If you're in trouble, just or raise questions or whatever. It doesn't matter, right? So how do you? So these are the things you have to actually think before you intervene. So patients' symptoms are important, size and sight. Okay. Let's take one by one. So symptoms. If you take abdominal aortic aneurysms, you do intervene when they are symptomatic, or when it reaches a certain size, like I said, 5.5 centimeters in diameter. Or if it is a thoracic aneurysm, you wait more than that. You wait until about 6 centimeters in diameter. If it is popliteal aneurysm, you wait until about 2.5 centimeters in size. If it is iliac artery aneurysm, you wait until about 4 centimeters in diameter. Likewise, different sites and size also matters depending on the abdominal site. Because whatever why we don't intervene before that is because it has its own problems. One of the major problem is if you talk about the aorta, it has significant morbidity and mortality when you go to treat. So aortic aneurysms do carry about 5% mortality. So if you have 100 patients and do operate, 5 of them will die. That is the problem. So there are a lot of studies which have been done in the past to assess this risk versus the benefit you're going to gain at the end of the operation. Like something called these are called trials, clinical trials. There's something called UK they have done for UK that has given very clear idea about how we intervene. When the aortic diameter is up to 4.5 centimeter in size in male, annual rupture risk is quite insignificant. It's about 1%. So suppose you're going to treat a patient who has a 4 centimeter aneurysm and there's a perioperative mortality of 5%. So what is the benefit you're going to gain? It's a negative benefit. So there's a 4% negative benefit. So otherwise you're going to kill more patients by if you try and do intervene. So that's why we wait until it reaches the significant risk level before you try to intervene. When it reaches 5 centimeters, 5.5 centimeters, annual rupture is about 5%. So that's why the risk versus benefit is quite compatible. That's why we do it. Okay. Are you okay with that?
Yes, sir.
Hello?
Yes.
Okay. Right. Any questions so far? You're asking, so I didn't get the question fully. There's some intermittent. Yes. Okay. So when it reaches, when aneurysm is aortic aneurysm is when it reaches 3 centimeters in diameter, we call aneurysm. So until it reaches 5.5 centimeters, there is the protocol you have to go by. You have to do annual screening, annual surveillance screening every year until it reaches 4.5 centimeter in size. What you do is get an annual ultrasound scan abdomen and assess the diameter of the aorta. So that's what you do until it reaches 4.5 centimeters. Usual annual expansion rate, there's something called annual expansion rate of the aortic aneurysm, which is about 0.3 centimeters in diameter. Is that clear? So if you are to develop the size of about 4.5 centimeter, how long will it take? So 1.5 centimeters increment. So that means 0.3. Hello? Yeah. So it takes at least how many years? Yes, 5 years. That's right. So you can comfortably observe these patients. So see the annually what you do is annual scan, ultrasound scan, and then get the patient follow up in your clinic. So when it reaches 4.5 centimeter, sometimes the annual expansion rate might increase. So in that situation, you have to watch them carefully every 6 months. You do a scan, ultrasound scan, abdomen every 6 months, 4.5 centimeter to 5 centimeters. And from 5 centimeter down every 3 months until it reaches 5.5 centimeters. So this is the plan. Okay. So the other thing is what you do is you have to give other medications. most important thing is you have to give pressure tablets. You have to control the hypertension, because I said when the pressure inside the lumen increases, the expansion rate becomes great. So you have to control the hypertension. And you ask the patient to stop smoking. So cessation of smoking is very important, because smoking is one of the most important risk factor for develop aneurysm. And also, we know the elastase activity and it has collagenase activity. You take when you do smoke, that's why you lose CVD. Same thing happens in blood vessels. So ask patient to stop smoking. The next thing is give some drugs like statin. So statin is a cholesterol-lowering tablets and drug which can cause control your cholesterol and reduces the inflammatory level of the plaques. So that leads to control of the other risk factors, because these patients do have coronary artery diseases and they have significant stroke risk, because this is the atherosclerosis the process, and they are going to modify the risk factors by giving statin. And most often we give aspirin as well, because aspirin is going to prevent cardiovascular mortality due to MI and stroke. So these two drugs, in addition to hypertension control, are very important. So this is what we do in those patients who have got aortic aneurysms before it reaches a particular size. The other thing you have to think about is to consider whether they are symptomatic or not. Symptomatic in the sense they have abdominal pain, back pain, and tenderness in the aneurysm. If you do palpate the abdomen is tender. That means it is symptomatic. Even though it is not, it has not reached 5.5 centimeter in size, we call it as symptomatic, and there's an indication for it to intervene, because symptomatic aneurysms do have increased propensity to rupture. So these are the clear two indications for it to intervene: the goiter size and the symptoms. Okay. Let's get to the other one. So these are the ways we can actually fix these aneurysms. It is a false aneurysm. You see only a defect in the arterial wall on one side. So you can simply, it is a hole is quite small. You can simply approximate. You can put some sutures and approximate the wall, adjoining wall. Most of the cases it is not possible. So you can go direct repair. You can cut the two ends and directly place those two segments together. Sometimes you can actually put a small patch into the defect and repair it. Some of the times you can actually ligate, like in radial artery. If there's pseudoaneurysm in radial artery, you can simply ligate it, because there's ulnar artery which is going to supply the palm. That's why I said if there are dual blood supply to a particular organ or the tissue, you can actually compromise or sacrifice on the artery. And sometimes you have to exclude this aneurysm, pseudoaneurysm, and you can do a bypass and ligate in between. Okay. So true aneurysms, they are usually fusiform. You can either ligate and do a bypass. When you do ligate, most of the time you have to do a bypass. That's what you usually do in popliteal artery aneurysm. You have to make an alternative channel for the leg to have blood to the leg. So that is ligation and bypass. And you have something called inlay graft. You have to have a graft, which I showed you previously. You have to have a graft inside the blood vessel and suture it end to end. Okay. Aortic aneurysms, if I go into depth of this thing, so it can be suprarenal, juxtarenal and infrarenal. Suprarenal is in relation to renal artery, you classify them. If it is lying above the neck of the aneurysm, it's very important to understand that the neck of the aneurysm is above the renal artery, that's called suprarenal. If it is neck is at the level of the renal artery, called juxtarenal. If it is inferior to that, it's infrarenal. So the 90% of the aortic aneurysms are infrarenal. So it has this clinical implication. One thing is that if it is infrarenal aneurysm, usually you can get when you to feel in the abdomen, when you do palpation, you can actually get above the lung. Clinically, if you can get above the lung, that means it is an infrarenal aortic aneurysm. If you can't get above the lung, that means it is suprarenal. So that's how it takes on clinical implication. It has its therapeutic implication also because it's suprarenal aneurysm. If you are to fix this, is quite challenging because you have to clamp this aorta superior to the renal artery level to fix that. In that sense, the kidneys are getting ischemia and going to renal failure. So that is having an extra morbidity to the patient. So that is quite challenging. So third year students, are you all understanding? Do you understand this thing? Anything unclear?
Yes, sir. Excuse me. Sir, could you explain if there's any implication on the renal circulation, if there is emboli formation as a complication, depending on the site of the aneurysm?
Yes. Usually, the renal artery is somewhat spared in aortic aneurysms. But sometimes the aortic aneurysms contain large amount of thrombus inside because the turbulent nature of the vessel. When the arterial wall enlarges, it forms thrombus inside, and this thrombus can actually migrate downwards down the floor. Sometimes, rarely, it can actually, not rarely, uncommonly, it can actually go and embolize the kidneys. That's true. If it is especially suprarenal, that will happen. But most of the time, the 90% of the aortic aneurysms are infrarenal, so it doesn't happen. But instead of it going to the renal, it can go into the lower limb, cause distal embolization. They can present as something called acute limb ischemia. Okay, so that is the other way they can present, other than rupture. So they can present as acute limb ischemia to you due to embolization. Is that clear?
Yes, sir. Thank you.
Okay. So this one I told you before. There's another entity called inflammatory aneurysm. So inflammatory aneurysm is another entity, entirely different pathophysiology. It's just kind of an inflammation in the aortic wall that is in about 10% of the aneurysms are inflammatory. That happens quite in young people compared to the older category I told you. This aneurysms are thought to be associated with advanced age, but this is happening in young age group. There will be marked thickening of the aneurysm wall. That means aneurysm wall getting edematous, and it gets due to inflammation. And there will be a lot of fibrosis in adjacent retroperitoneum. So these are things you can actually appreciate in CT scan. So this is how aortic aneurysms present. They may be asymptomatic, just an incidental finding, or they may present as self-wet lung, or they may be asymptomatic aneurysm. So the complication I told you before, it can be due to rupture, it can be due to thrombolism and embolism. So if it is ruptured, can can have. I explained about this before. So this severe constant abdominal back pain, hypotension, tachycardia, and ulcerative gastric mass, abdominal mass. Before rupture, they are usually symptomatic. They can get just a vague epigastric discomfort. There may be sometimes back pain, abdominal pain, which is very non-specific. So in this situation, you need to have index of suspicion. So usually in palpation, you should be able to feel a lump, which is expansive. Right. So examination, you should feel expansive mass. I told you the aorta, if you feel above the aorta, usually above the umbilicus, because the aorta ends at L4 level, and if you feel below the umbilical level, unless the abdomen is pendulous or protuberant. So if below umbilicus, you feel it's more like iliac artery. So this is just rough guidance for you to go by when you do clinical examination. So I said now, if you can get about the, can feel about the upper border in the abdomen, it's more likely infrarenal. If you can't, it is suprarenal. So maybe just expansive mass. Okay. Investigations. So as I suppose explained initially, so these are the type of investigation we have to request. In his as well as routine and emergency basis, these are things we need to investigate. If you're a special house officer, these things we need to do. You need to do a full blood count, electrolytes, do a function test, coagulation test. Most important, coagulation, because these patients, when they are unstable, they may have some coagulopathy due to bleeding. So you need to request coagulation test. APTT, test, right? PTINR, and sometimes we might request to take, so that's thromboin endoscopy. That will give a good value of assessment about the coagulation status. And you check the blood lipids as well in stable patients. Diabetes ruptured, obviously, you had to cross-match at least 6 pints of blood. So this is a must. So you need to request at least 6 pints. You check the cardiorespiratory functions. I think if you go by the previous records, there may be evidence of these things. In elective patients, if the patient has rupture, so you need to assess them thoroughly, cardiorespiratory reserves, by doing their functions, cardiac functions. You do stress echo sometimes, you do echo and stress echo, ECG, things. And the respiratory function is important because when you do open the abdomen, you have to your diaphragm get compromised because respiration will affect due to pain in the abdomen. So unless you have good respiratory reserve, you might not be able to breathe. So one of the peripheral mortality is due to respiratory problems like pneumonia and lung atelectasis. So they develop a lot of these complications. And if you have good respiratory reserve only, you can do perform well after operation. So see, these are important, very important for you to do before you plan an operation. But
excuse me, sir.
Yeah.
Sir, the like previous question, if we not gonna operate on him, is there any value for the electrolytes and liver function test? Yeah.
Not so, actually. That is a separate entity that's called conservative management. We are not going to do anything more because if you know for sure the patient is going to die. If the aorta has ruptured, you're not going to live long, maybe a maximum 48 hours. So you're not going to do anything more. That's right. So, but if you're going to intervene, these things are important.
Okay. Sir, thank you.
All right. So you have to assess the morphology of the aneurysm by scan. Before you rupture, actually rush the patient to the theater, you need to assess the morphology of the aneurysm. If the patient has stable blood pressure around 100 or so, that means patient can withstand the CT for another few minutes. Like you can arrange the CT as early as possible. Within half an hour, most of the time, most of the centers, you can arrange the CT. Because the CT gives a good evidence as to what kind of aneurysm it is. It may be a suprarenal aneurysm, or it may be a thoracic aneurysm which has ruptured, or it may be just simply infrarenal aneurysm. Okay, so because if you thoracic aneurysm, you're not going to do an operation for it. This kind of, it's not simple operation because it has even if you open up, it's going to die anyway. Because thoracic aneurysms are having worse outcome. So that is why CT, if possible, have a CT. If it's quite unstable patients, you will take the patient to the theater as early as possible. But have some idea as to what kind of aneurysm it is. Because the patient is unstable anyway, this patient is going to die if you're going to leave the patient, whether you do CT or not. So that's why you rush the patient to theater and see, open up and see by yourself. The artery is suprarenal, infrarenal. The infrarenal, you are lucky, you can fix it. If it's suprarenal, you might still be able to get a aneurysm repair, but you're going to compromise the renal artery by cross clamp. So in that situation, if it's thoracic aneurysm, you might not be able to fix it. So you say goodbye and come back. Okay, it's like that in an emergency unstable patient. But in stable patients, you do assess the CT scan. Is that clear? It's very important when you become house services. You need to get these things into your mind at this stage. Is that clear? Hello?
Yes, it's clear.
Yes, sir.
Okay, good. So this is when you do a scan, this is what you see. You see a sac, large sac there, and you might see some flow there. This is but it's very vague, isn't it? Because the bowels in front of you, it will not give a morphological description of what it is. And you have to actually measure the diameter, maximum diameter. So this is the posterior wall, this is the plaque, and also there's a thrombus in it. Some of the times the radiologists actually measure the diameter of the lumen from here to here. That is highly inaccurate because it's not the actual diameter of the blood vessel. Actual diameter is from here to here. So that is the diameter you are interested about. But this is also highly dependent on the operator. That's right. So it is highly vague and also depend on the operator, because if you take wrong angle, you can give a false enlarge or false estimation of the aneurysm diameter. Okay, but good hands, it gives a good value, but it is highly subjective. CT, on the other hand, is highly less biased because anyone can actually see that and give the exact diameter of the aneurysm, which is you're interested about maximum diameter. And you can actually say whether it's a suprarenal, infrarenal, or it is aorta, or it's aortoiliac disease, or a lot of information. And actually can actually plan your operation. It is you are talking about the neck of the aneurysm, where there's a kind of angulation of the neck. These are important when you do a keyhole operation. I'll explain it later. So there are two ways you can actually plan: surgical and endovascular. You can actually check whether it's there's a leak in the by the CT scan, because ultrasound may not actually reveal a leak. So this is what you see. So you see the aorta, which is contrast. I can see contrast extravasation. You see, outside the blood vessel, you can't have contrast normally. So they see contrast extravasation. You see a large hematoma there, filling all the retroperitoneum. You can see it's going up the left side as well. So this is what you see. Usually in the fresh bleeding, fresh hematoma appears hypodense by CT. So this is what you see. And you see the actual defect. you see this is the vessel wall, and there is this site where it has ruptured and causing all this blood. You see the kidneys are pushed forward. Can you see? This is the retroband. This is the kidney on this side, and this is the kidney on the right side, which has been pushed forward because of the large retroband. Is that clear? Is that clear?
Yes, sir.
Yes, sir.
Okay. Yeah. Okay. Right. So these are the other signs. So you can see in CTs, you can see the usual aortic wall has calcifications. You might detect in the CT aortic wall has calcification. If there's a defect in the calcification, you can think that there's a leak there. So there's a discontinuous calcification. So there's extravasation of blood there. So the same thing here, same thing there as well. So good lot of information. Right. So I told you about the diameter of the aneurysm, why it's important to go by, and whether it's symptomatic. So other thing I forgot to tell you about was whether there's a complicated aneurysm or not. So if it is complicated, means it has got some other secondary cause like infection. So infective aneurysms have increased chance of rupture. Because usually infective aneurysms, I said it is mostly saccular. It is not fusiform normally. Because in the one side it has gone and it causes saccular aneurysm. So these are three clear indications for us to fix the aneurysms, aortic aneurysms. So diameter, symptomatic, and it's complicated due to infection, which is not actually fusiform, which is saccular aneurysm. Okay, so I explained to you this about this law of Laplace, T equal E into R. You can understand that. So this is a guidance you have to go by. If less than 4 centimeters, the rupture risk is 0, estimate to be 4 and 5, but still, but rough estimate about 1% annual rupture risk. When it reaches 5.5, so 5-6 centimeters, but mostly about more than 5% rupture risk. It can reach 6 centimeters, but 15% rupture risk. Likewise, rough estimate. You can actually see that when it is about 8 centimeters, so there's 30 to 50% annual rupture risk. So if you follow up 100 patients, 50% will rupture. So this is the study that I told you about, UK small aneurysm trial, and there's so you have see the they have 2 randomized people into early surgery versus surveillance. The straight line depicts the surveillance, early surgery group, versus the dotted line shows the surveillance group. There is no difference. In the small aneurysm, less than 5.5 centimeters, there's no survival advantage. Okay, so I told about surgical risk. This is open surgery. It carries about 5% mortality and morbidity of 5-10% in cardiac events. They get MI and stroke. So, choice how you do fix these aneurysms. There's a rough guidance how you go by in young patients, relatively young, in the sense less than 60s. If they have good cardiovascular reserve, you do a fixed aneurysm by open technique. So open aneurysm repair is the best way we can do to fix aneurysm in cardiovascularly fit young patients, relatively young patients. But it's elderly. If more than 60s with some cardiovascular compromise, keyhole procedure would carry the best outcome. And because if you do fix the aneurysm by endovascular means, the therapy mortality is around 1 to 3%. So that is very minimal. But problem with keyhole procedure is that there is a lot of surveillance after fixing this, because it's you have to annually see these patients with repeated CT and see whether they are doing okay because the stents, which whatever things you are putting in, can migrate and have a lot of other complications. But whereas if you do open surgeries, they are going to have initial perioperative mortality of 5%, but once they recover from that, that's done for the rest of their life. You don't need to do much of surveillance. So this is how you do when you do open vessels, the abdomen. So we cross clamp and then we open the blood vessel and we fix it. This is what we do. We put a draft inside. Inside this is sac, aortic wall. We once we suture the end to end. This is a prosthetic draft, which is made of fabric. And once you do that, you have to close this sac over the draft. This is what we do. This is the actual case scenario. So we see the draft, which is lying inside. This is the sac wall, aortic wall, and you. This is the graft. Okay. The other technique is called endovascular aneurysm repair. We call in short form like EVAR, EVAR. Where you put stents inside this aortic aneurysm to curtail or prevent the leak. So this is the renal artery. You're going to preserve the renal arteries. You're going to fix, put a prosthetic graft by keyhole thing. It's delivered through a tube layer and can expand. It's like an umbrella which you can open up. It has metal devices there, which has some system to hold it there to prevent migration, and they're going to exclude the aneurysm from inside. So this is the keyhole. You usually go through the femoral artery through keyhole. So that's the beauty of it. So these are different stents. You can see that it's like a flower here. It has hooks and barbed system. There are some hooks which actually hold the vessel into the vessel. Once we open like umbrella, it's going to hold inside the vessel by these hooks and barbed system. All right. So these are the complications, known complications after open aneurysm repair. So one of the biggest thing is about bleeding. So aorta, carries huge amount of blood. Within about a minute, you can, if you do open aorta, you can exsanguinate and die within a minute. So bleeding is the biggest thing, and due to the blood loss, you can get coagulopathy because abdominal aortic aneurysm operation. They are uncompromised. If it's ruptured aneurysm, the patient is already in a compromised state. They can have accompanying coagulopathy due to bleeding. And due to aortic cross clamp, because what we call clamping of the aorta above the aneurysm, that causes increased myocardial load. So the pressure build up above the level, and that causes increased cardiac load and heart attacks. And the other thing is what they can give visceral organ ischemia, like kidneys can suffer due to ischemia, renal dysfunction. The visceral organs like bowels, they can cause bowel ischemia. Most importantly, the spinal cord, they can suffer ischemic event. The spinal cord has blood supply, segmented blood supply from the aorta. One of the important blood supply is called artery of Adam-Kivi. That's usually is there T9 to T12 level. There's a perforating artery given by the thoracic aorta. So these arteries segmentally giving blood supply to the spinal cord. And there is a blockage, or when you clamp these arteries, that can cause ischemic injury to the spinal cord, and paraplegia. Sometimes these can cause because I said there are the thrombus inside the blood vessel that can cause distal embolization and acute ischemia. So late we can get actually arterioenteric fistula, because if there is graft getting exposed to the bowel, that can cause fistula between bowel. Mostly the duodenum getting affected and called duodenal fistula, and can cause catastrophic bleeding. So I told you about the EVA. So this is these are some of the criteria you usually go by. These are too much for the students, but I just made some facts. If you want to study more, the EVA for endovascular aneurysm repair. This is a graph I showed you before, and this is how to do. I explained it. And once you fix this aneurysm, this is what how it's been seen by CT scan. Okay, let's get to the peripheral artery aneurysms, popliteal aneurysms, which is the commonest peripheral artery aneurysm is popliteal artery aneurysm, and it's commonly bilateral. When it happens in one side, you have to think about the other side, contralateral artery aneurysm as well. In the 60 to 70% of times, you might get a bilateral popliteal artery aneurysm, and 30% of the time you can get a aortic aneurysm also as a accompanying factor. So those who have got popliteal aneurysm always do check the abdomen, see whether there is aortic aneurysm also. Diagnosis confirmed by Doppler scan, because CT is not mandatory in peripheral arteries, because I said the bowels are not there, so you can get a good image of the vessels, and you can actually get supported evidence by CT or scans. Usually we don't treat under symptomatic popliteal aneurysm or until it reaches 2.5 centimeter in size. What do you call as symptomatic popliteal aneurysm is because if it has given rise to embolization causing distal ischemia, so that is the indication for it. Are you all clear with that so far? Third year students?
Yes, sir.
Yes, sir.
Is it too much for you all? You all understand this, do you? If there's anything unclear, just let me know, okay?
Okay, sir.
Right. So the other thing you need to know about is this dissecting aneurysm. So this is actually called dissection. So this is not aneurysm. So dissecting aneurysm is a misnomer. So you need to get clear with this terminologies. So there's a kind of when you do anatomical dissection of the body, you dissect in between planes. Like in aorta, you can get a dissection, spontaneous dissection of the aortic wall in the media. So that bisects the vessel into something called true lumen and false lumen, like this. So you can have a condition called dissecting aneurysm. So there are the different classifications. You don't have to know about all these things. This is how we fix that. So again, too much for you all. Just for your information, and when you're interested, you can read around this. These are the keyhole things, operations you do. And this is how it appears in chest X-ray when you do fix it these conditions by endovascular means. So this is the stent you can see. You can see the metal device inside. Okay, last is the arterial veins malformation called AVM. AVMs are usually classified in two forms. Mostly they are congenital, but they can happen due to some iatrogenic injuries or traumatic injuries. There's abnormal communication between artery and vein. That's called AVM. So that actually bypasses the capillaries in the circulation. That causes that can cause two things. That can cause reduced oxygen supply to the periphery when they have a major part of the blood being bypassed back to the heart. You can get decreased blood supply to the distal extremity. And the other hand, it causes increased oxygen in venous blood, and that causes more demand to the heart because you do a lot of your heart has to work harder now because there's increased backflow from the venous side that causes eventual ventricular hypertrophy, can cause heart failure. So these two things can happen due to artery venous malformations. But mostly these aneurysm artery venous malformations are quite small. They're congenital and they do enlarge with time. With the aging and all, these to enlarge and can cause significantly enlarge and become symptomatic later in life. So these are classified into major forms called low flow and high flow system. It does reduce artery-venous communication that's called low flow, which is primarily high artery or major artery getting communicated with the vein called high flow. So that's called two major categorization. I said when either is congenital or acquired, and so you have something like this artery getting communicated with the large vein. So can cause sometimes the artery venous communication. They can lead to hemorrhage. Can cause hemorrhage presentation due to hemorrhage. I said they can present ischemia and can cause as mass effect like increased ICP or like berry aneurysms. Berry aneurysm is not a arterial malformation. In the legs, this happens due to venous arterial malformation in the legs mostly. That can cause increase in pain and sometimes can cause mass effect, like compartment syndrome in acute hemorrhage. So you have to image with a CT or MR. Mostly, sometimes a duplex scan will reveal the things, but more information is gained by doing CT or MRA. How you manage is you have to either surgical resect. If it is quite small, you can leave alone unless the patient is quite symptomatic. If it is symptomatic, obviously you have to fix it by surgical resection, or by minimal invasive techniques, you can actually embolize. You can actually embolize the feeding artery, and that can lead to shrinkage of the malformation. Yeah, that's it. Any questions?
Sir, I have a question.
Yeah.
To investigate abdominal aortic aneurysm, can we use angiography? Does it rupture the aneurysm, or can we use angiography?
Sorry, your question is about the investigation of the CT angiogram, is it? Or DSA?
No, sir. Can
you
we?
Conventional angiogram, is it?
Sir, to investigate abdominal aortic aneurysm, can we use angiography?
Yes.
Can we use angiography?
Yes, we do angiography because angiographies are three different forms. One thing is called conventional angiogram. That's called DSA, digital subtraction angiogram. That is an angiogram. It's actually what you see is a lumen only. Okay, so that's angiogram. Whereas CT angiogram is called that's angiogram again, but gives more information. That gives an anatomical description. MRI. Hello. MRI is also gives actually gives a lot of information about the status of the aneurysm. So all these three things are angiograms, but three different forms. But conventional angiogram, if you talk about conventional angiogram, that's called DSA. Actually, sees only the lumen, but mostly you want to get the information about the vessel wall, because that's where we have to see the vessel, how much it's dilated. Because if you see the lumen, you can see the thrombus. You can't see the thrombus inside. You know the difference between the luminogram and the CT. The vessel wall. In the lumen, you can see only the actual diameter, normal diameter, or maybe only the patent lumen. Whereas if there is a thrombus in the vessel, you can't actually see that. Do you understand the difference between those two?
Yes, sir. Thank you.
Yeah. In CT, actually, you can see the vessel wall. Okay.
Thank you, sir.
Okay.
So in management of the patient with aortic aneurysms, other than stop asking to stop smoking, sir, like what about, do we, condone him into a exercise regimen, and what about things like training and other things? Is there any like more to his lifestyle advice parts?
Not necessarily. I mean, if they do exercise and all this, there's no relationship with exercise and this thing. But sometimes these in other parts of the world, the aneurysms do rupture in certain seasons, like winter, they rupture. There may be some emotional component associated with that. But exercise and all the other lifestyle modifications not quite important. But if you're quite obese, obviously you have to control your weight and all. But most important factor is the control of hypertension and smoking. Other than that, there's nothing, no other lifestyle modification going to make changes in the progression.
Okay, sir. So I have read that arteriovenous malformation in limbs can be life-threatening. Why is it that? How does that happen, sir?
Yes, it can be life-threatening because it can lead to catastrophic hemorrhage. I said now these newly formed vessels, arterial malformations have fragile vessels. Sometimes they just sometimes behave as tumors. They form this neovascularization inside this. So these are fragile ones. They can rupture easily, and leads to catastrophic hemorrhage. So that can be sometimes life-threatening.
Okay,
Or it can be it can be limb-threatening if it is due to the ischemia, because the major part of the blood is diverted. Okay.
Okay, thank you very much.
DSA, there's nothing called contraindication. There's no value in DSA. Okay. There's no added value. So it's inaccurate diagnosis, inaccurate imaging modality.
Could you explain the risks? Excuse me, sir. So could you explain the risks associated with performing an angiogram, a CT angiogram, in a patient with an aneurysm?
Pardon? What's that? Sorry.
Could you explain the risks associated with performing an angiogram?
Yes, risk associated with angiograms. That's so one risk is that if you talk about the CT angiogram, so you have to give something called contrast. So this white color stuff there, that's the contrast. So that is iodine-based contrast usually. Okay, so it has its own problem. One thing is can lead to allergic reactions. Some of the patients who are fish allergy or these things can have allergy. So allergic reaction is one of the significant things you are worried with. So you have to ask about, have to be careful about the kidney functions. The kidney function should be stable because this iodine contrasts are hypoosmolar, right? So hypoosmolar contrast will damage the kidney. So if your kidney function is quite impaired, suppose your creatinine is high, so you can actually lead the patient to a acute renal failure. So these are the two important risks associated with the contrast and the angiogram. Okay.
In that case, is it mandatory to perform a renal function test before going forward with the angiogram?
Definitely. Yes, definitely you have to assess the renal functions before you do in contrast study. It is applicable to each and every investigation in surgery. Contrast study. Okay, whatever the contrast study you're doing, you have to assess the renal functions.
Okay, so thank you.
Somebody is asking about the figure of 8. We heard it is in a way of suturing of a bleeding vessel. Okay, so figure of 8 actually is kind of a suture you put to occlude the vessel, to occlude the bleeding site or whatever the opening. Like it's not applicable to blood vessel only. You can apply it anywhere. Maybe even the blood in the bowel, but is like a figure of 8. It's like a purse string. It has a purse string effect. How do I draw that? But you all actually can learn it later on. If you're a third year student, you can learn that when you come to surgical clinicals. Okay. So this is actually I wanted to explain this about the luminogram and the CT angiogram. So this is the luminogram. If you do the DSA or digital substrate angiogram, this is all what you see. The rest of the things will not be seen. But if you do CT, you see a lot of other structures, surrounding vessels, the actual vessel wall, because there's a thrombus inside. That will not be shown in the DSA. Is that clear? Hello? Hello? Okay. Any more questions? Third year students, are you all happy?
Yes, sir.
Okay. Anything more to explain, or you're happy you can wind up? If there are no questions.
Excuse me, sir.
Yeah.
I have one question. Sir, if we are suspecting a patient is having rupture aneurysm, what about his venous axis as a house choice?
Oh yes, we have to put 2 white bore cannulas. So 2 white bore cannulas, 16 gauge or 18 gauge. 2 white bore cannulas have to put to either sides. Because we have to have the arterial venous access. That's a very important question you asked.
So what about the blood pressure do we have to maintain?
The blood pressure is 100 is satisfactory. We maintain something called normotensive hypotension. Normotensive what it is it's permissive hypertension. That's the term called permissive hypotension. Because if we increase the blood pressure, that causes again the rebleed. So 100 blood pressure is quite satisfactory. We don't increase the blood pressure more than that. Okay.
Thank you, sir.
Anything more? We will upload this thing. I think I'm not the host this time, so somebody else has been the host. So whoever has hosted might have recorded it. So please upload that. But I have the previous recording, so I'll upload that as well. To which one? To the cal. To the cal. Okay. Okay. All right. We'll do that. Sure. But the major part of the recording is not with me, to be honest, because I was not the host. Somebody else. Yeah. Okay. Okay. Good. I'll do the rest. Somebody is asking privately. Anything else? Could you please repeat the surgery of ruptured infrared aneurysms? So are you not clear about the aneurysm management if ruptured? Suprarenal and infrarenal aneurysms, I told you, because we have to cross clamp the aorta when you actually want to fix it. So this is the level of renal artery, and we have to clamp it. Otherwise, it will bleed in it, isn't it? When you want to fix it, like when you open the vessel, it will bleed otherwise. So in order to prevent bleeding, you cross clamp it like this. It got arterial clamps. So if it is renal aneurysm, we have to clamp above the renal arteries. So that causes renal ischemia once you cross clamp. So that is a problem. So that can cause acute renal failure. Okay, so that's the difference.
Excuse me.
Yeah.
What are the investigations that have to be done for the dissecting aorta and the AV malformations? How do we?
It is the same set of investigations. Like if you image, because a dissecting aneurysm is a different entity. It is it is a dissection happening in the aorta. So it usually the investigations are the imaging and also biochemical imaging. The biochemical investigations like normal blood counts, but there is no actual extravasation blood here. So it's all inside the vessel. There's a different. There's something called true lumen and a false lumen. The biggest problem with it is there's a entry point of the blood into the false lumen somewhere here. That causes a dissection. Due to the pressure inside the aorta, this dissection progresses downstream. So that is what happened. And we have to image by CT scan, CT angiogram. So that's what we do in dissecting aneurysms.
So I read somewhere about the echo, transesophageal echo.
Yes, that's right. So I actually didn't touch much about dissecting aneurysms. There are actually two types if you want to elaborate on these things. So there's something called type A and type B. Type A aneurysms is the one which dissection is one which is deadly. Which can actually go into the other way, usually goes downstream. But if the entry point of this tear is going is proximal to the left subclavian artery is called type A. Okay, entry point means there's a dissection here, and the entry point is proximal to the left subclavian artery is called type A. It is beyond that we call type B. So type B aneurysms are managed differently, whereas type A aneurysms are managed differently. So you have to get an echocardiogram done to rule out the possible type A. Sometimes the dissection can go upstream and cause aortic valvular root dissection. If that happens, that can cause acute heart failure and patient can die suddenly due to valvular prolapse and then myocardial ischemia. So echocardiogram detect whether there is a type A dissection. Usually CT will be able to tell all these details, but especially if you suspect type A, you have to take to do an echocardiogram. Mostly the transesophageal echocardiogram would be the best. Okay?
Okay, sir.
All right.
Okay, thank you, sir.
Okay.
Is that the same thing that they call the double barrel aorta?
Double barrel aorta, something like that, yes. But it's very lay people who call double barrel, but is actually we call it true lumen and false lumen.
Okay, sir. Thank you very much.
All right then. If it is at yeah. Yeah, sure, I'll do that. Okay. Then shall we wind up? I think the third year students have another lecture at 9 p.m., isn't it? Dr. Bag is doing that, ne?
Yes, yes.
Okay. Okay then. See you then.
Very much.
Bye.
Thank you, sir.
Thank you. Good night.
Okay. Good night.